So good evening again. So the task that was given to me was to do a systematic review of the semiology of temporal insular seizures. And I fought with Philippe to have the topic of insular epilepsy, but unfortunately I lost, so I had to take this one. So I knew from the get-go that it would be a difficult topic to address. We'll see in the end if temporal insular epilepsy is more than the sum of its parts. This is the plan of the presentation. So as you know, temporal lobe epilepsy is the most frequent type of drug-resistant focal epilepsy that can be surgically remediable. However, the success rate of surgery in temporal lobe epilepsy is only moderate, and previous authors have suggested that some of the surgical failures have an epileptogenic zone extending beyond the temporal lobe, such as the insula, which is located right behind the temporal lobe. So Penfield was the first to suggest this. In fact, for many years, he and Jasper did intraoperative ECOG recordings of the exposed insula after the removal of the temporal lobe to determine if they should remove the insula or not. They stopped doing so when they realized that chances of seizure freedom were not significantly improved, but that complication rates were higher. And this is possibly explained by the fact that the decision to remove the insula was based mostly on the fact on the presence of insular interictal epileptiform discharges rather than the demonstration of seizures. Although Sylvanus mentioned in his paper the presence of seizures on some ECOG recordings, these were defined by bursts of epileptiform activity of 2 seconds or more, so I'm not sure if there were really seizures. Actual recordings of insular seizures extraoperatively was first reported by Jean Isna in 2000, and as a matter of fact, it was in 2 patients with temporal insular epilepsy, since these 2 patients also had independent temporal lobe seizures. And after that, several series of pure insular seizures and opercular insular seizures by our group, and many people here in this room have followed, but this is not the topic of this talk. So let's take a look at the connectivity between the 2 protagonists. They are heart wires. Let me take the mouse here. They are heart wires. They are not very impressive, but they are well placed. The temporal insular tracts anterior and the temporal insular tracts posterior, connecting mainly the lateral temporal lobe, the pole, and the superior temporal gyrus to the anterior and posterior insula. You can see them here as well. And the mesial structures are also engaged with the insula, the amygdala via the amygdalo-insular fasciculus, and the hippocampus through a bit more complex pathway with connections mainly with the ventral insula, both in its anterior and posterior portions. Concerning semiology, we have already seen from yesterday's talk that semiology of temporal lobe epilepsy is in itself a complex affair with 3 or 4 subgroups: mesial temporal lobe epilepsy, lateral temporal lobe epilepsy, temporal polar epilepsy, mesiolateral temporal epilepsy. And let's not talk about the complexity of insular seizures, which Philippe will talk about later. So arriving at temporal insular epilepsy, what do we know? What we know is mostly informed by personal expertise and based on small series, and it's summarized here in this table by Carmen Barba. Red flags include occurrence during sleep, reflex seizures, subjective manifestations such as throat laryngeal constriction or breathlessness sensation, orofacial paresthesia, shivers or goosebumps, painful paresthesia, gustatory hallucinations, bradycardia, facial or facial brachial jerks, hypermotor component. So are these red flags a myth? So to answer this question, performing a systematic review is a good starting point. Here is our strategy. Studies had to be related to epilepsy, of course, be related to temporal and opercular insula. Patients could be part of larger series on temporal plus or temporal perisylvian epilepsy. And we used a search strategy that had been previously validated for epilepsy studies and described by my colleague in this paper, a study by Mark Kieser. So we searched the classical databases and the gray literature, and here's an example of our search strategy in Embase. So studies were included if there were original studies, if they contain at least one patient with temporal insular onset, based on the presence of a clear temporal insular epileptogenic lesion or SEEG, or seizure freedom after surgery. And case reports were included if they were deemed informative by all the reviewers. Here's our PRISMA flowchart. Our search strategy provided with over 1,700 citations, and after removal of duplicates, we screened over 1,300 studies. After initial screening, 98 full-text articles were assessed for eligibility, and several references were then excluded because they were abstracts only, or the semiology was not provided, or the patients did not have temporal insular epilepsy. In the end, we were left with 18 studies totaling 80 patients. Now you've seen this kind of table several times now since Monday. Note that apart from the first paper with 46 patients, the rest are case series containing only 1 or 2 cases of temporal insular epilepsy or case reports. The first and largest study was a head-to-head comparison of 51 patients with temporal lobe epilepsy versus 46 patients with temporal insular epilepsy. However, the level of confidence for this large study was low because there was very little detail provided. The number of patients with positive MRI was not provided. We don't know how many had intracranial EEG, and we don't know how many were operated. The rest of the case have in general undergone SEEG and were operated on. So here's the summary table. So there was overall 80 patients with temporal insular epilepsy, but only 40% with high or very high level of confidence in the epileptogenic zone. 69% were adults, a third had positive MRIs. This does not mean that the lesion involved the temporal lobe and the insula. Many of them just had hippocampal sclerosis, for example. A third had SEEG studies, and most of them were operated, and 2/3 had a class 1 angle outcome with a follow-up of more than 1 year. So what anatomo-clinical correlations can we make with the 32 patients for which we had a high degree of confidence that they had temporal insular epilepsy? So 22% had fear, anxiety, 22% had somatosensory symptoms, 16% had epigastric or abdominal auras, 9% had a throat sensation, 9% had auditory symptoms, 6% had olfactory symptoms, 3% had nausea. Moving on to later signs, 31% had oral alimentary automatisms, 13% had hand automatisms, 16% had autonomic manifestations, mainly hot flushes and erythema. 13% had hypersalivation or spitting. And 9% had hypermotor manifestations, 9% dystonic posturing, 6% blinking, 3% clonic jerking, 3% contralateral head deviation and eye deviation. Oh, sorry, I forgot to move the slides. Okay. Okay, and so these observations coming from high confidence level cases are a little bit similar to the large study I talked to you about who had 46 patients with a low level of confidence regarding the epileptogenic zone. It's a study that was published in 2022 in Neuroscience and Behavioral Physiology, which publishes translations of significant papers from top Russian journals in brain physiology and neurology. So this study is the only one with a large head-to-head comparison with temporal lobe versus temporal-insular epilepsy patient. But as mentioned, the confidence level was low because there were very few methodological details. But in essence, what authors found was that patients with temporal lobe epilepsy had more frequently emotional symptoms, anxiety, panic, fear, erythema, pallor, nausea, hypersalivation, sensory symptoms, and simple motor signs. Again, we have to be careful about what comes out of this study. When I read it, there were a few details that bugged me. The little bits of information that was provided was sometimes disconcerting because, for example, the authors had two figures. This first figure here was a patient with in the temporal insular group, but the lesion was in fact here, this one. The lesion was in fact opercular insular, and this patient here was supposed to be in the temporal group, but there's a lesion in the frontal opercular region, so I'm a bit concerned. I'd like to finish with two illustrative cases of temporal insular epilepsy in our institution. So the first case shows some of the features I showed you in my systematic review. So she's 23. She had meningitis at 10 months of age. On MRI, she had mild right hemispheric atrophy and right hippocampal sclerosis. And seizures were characterized by left hand paresthesia, a throat sensation, an ascending epigastric sensation, vocalization as you heard, with or without impaired consciousness, and sometimes if she was standing up, she would fall to the floor. So you can see here some of the features I showed you in the systematic review: fear, anxiety, somatosensory symptoms, epigastric sensation, a throat sensation, and hand automatism. Here's another example. This woman had a prodrome. It lasted about an hour before her actual seizure. She felt palpitations, difficulty swallowing. She would have more saliva, so she would swallow it all the time. And at the moment of seizure, she would feel that her chest and her throat and her jaw was swollen. And after that, she would have altered consciousness. She would have anxiety, and then altered consciousness, and then verbal automatism. You can't hear it because there's no sound, but she would repeat, no, 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 or thank you, thank you, thank you, I'm sorry, I'm sorry, I'm sorry. And then she would spit. So for both patients, intracranial EEG showed simultaneous ictal discharge involving the temporal and the insula, the temporal lobe and the insula. The first one, the hippocampus with the insula. The second patient, the hippocampus and the lateral temporal lobe and the insula. So, what can we conclude? So there is very little number of cases to learn from. The reported semiology of temporal insular epilepsy is heterogeneous. There's no singular specific symptom or sign that we could delineate from the systematic review. Signs or symptoms classically found in temporal lobe epilepsy and insular epilepsy are found in combination. So for example, classical temporal lobe symptoms of fear, déjà vu are present, and classical insular symptoms like throat sensation, somatosensory symptoms are found. And the most commonly reported signs for temporal-insular epilepsy, according to a review, was the presence of automatisms, autonomic signs, and simple motor signs. So it would be useful for, in future studies to have more precise and standardized description of cases when reporting semiological features. For example, we had to exclude many patients with temporal perisylvian and temporal plus epilepsies because we did not know if they were temporal insular cases or not. And I finish by raising some questions for my colleagues. It's clear we need more good quality studies, but do you really think we will one day be able to distinguish patients with temporal epilepsy from patients with temporal insular epilepsy based on semiology? Because we know that the discharge quickly spreads and frequently spreads from the hippocampus to the insula. And so is it something we will be able one day to resolve? And also, this is more controversial, of course, it's to discuss, but does it really matter? Would our current way of practicing change? When I did this systematic review, there were, and it's my own experience, patients with hippocampal sclerosis or patients with temporal insular epilepsy. When you do an anterior temporal lobectomy, many of them feel they're much better. And they have remaining insular seizures, but these insular seizures are less frequent. Sometimes they can be managed by medication, or sometimes there are seizures without impaired consciousness, and sometimes you can see a running down phenomenon. So you can see in the case reports that I read, and I've experienced the same thing in my practice. Sometimes it goes away, sometimes it's controlled with medication. So should we try to recognize them beforehand, implant them, and make a guided resection, or should we just go for the lesion, do an anterior temporal lobectomy if there's a lesion or hippocampal sclerosis, and leave the SEEG study for patients who continue to have disabling insular seizures, but then with the SEEG, you have the option of radiofrequency thermocoagulation or LIT. So that's it for me. I would like to thank Faisal Zinedine, who did most of the work I've shown you, and Olivier Aron, who contributed to the systematic review, and of course the organizing committee for inviting me.